and 2 lectures as usual. The first lecture will be with Professor, hopefully Professor soon, Dr. Ahmed Mady. So it's a good omen. Dr. Ahmed Mady is actually a clinical assistant professor in 2 universities. I know a little or very few people that's working as assistant professors in 2 universities. So King Saud, Al-Imam Muhammad ibn Saud University Hospitals in Riyadh, Saudi Arabia, and he is assistant professor of anesthesiology and intensive care as well in Tanta University Hospitals. His main interest is critical care. He's working as a critical care consultant for maybe 20 years or even more. So I trust Dr. Ahmed Mady tonight will talk to us and will take us through a journey from the Rivers et al. Trial, crossing by the 30 ml per kg sepsis campaign guidelines. We may end up discussing the Clover's trial that's recruiting patients still. So this is our ICU daily challenge with fluid resuscitation. When to start, how to stop, when to stop, how much fluids. Is there a standard of care in the fluid management, or is there a best technique? This is what we may explore tonight with Dr. Ahmed Mady. So Dr. Ahmed, please, can you start sharing your presentation and go ahead?
Sorry, I'm mute now, yes. Assalamu alaikum, everyone. Thank you, Dr. Walid, so much for this very nice presentation. And really a great effort to deliver this a course over a 6 month. And weekly we have a session of from eminent speakers worldwide. And I'd like actually to thank all the faculty joining and sharing this event. Bismillah ar-Rahman ar-Rahim. Today we will have just insight or highlight about the patient in ICU. Common scenario, we have it in ICU, patient in sepsis or in septic shock. Does he need fluids? Does he respond to the fluid or not? And I'd like to disclose that I retrieve a few slides from some figures worldwide, like John Tupoul. And actually, I'd like to thank him. He gave me permission, and he gave me his slides since 2007. And Prof. Muhammad with us from Alexandria. At that time, he was presenter in ASAIC in 2007, and I met him for the first time, Prof. John Tupoul. And he is eminent, and he's one from the figure, as well as some slides from Mayatra, from the Baker, a few slides, and others are mine. We have to talk today about some sort about fluid responsiveness. Does my ICU patients need fluids or not? I'd like to share with you this case scenario. Let us start. If we have 55 years old male patient with history of cancer colon, and he has inferior MI with ejection fraction 40%, presented with intestinal obstruction. 4 liters of fluid was given in the ward before he would come to the ICU. Then he presented with tense distended abdomen. Post-op. He's ventilated with high setting of mechanical ventilation, as you can see it here, FI2 70% with PEEP 15. Leukocytic count rising to 18,000. He has the highly fever, highly febrile. Tachycardic, blood pressure 80/50 millimeter mercury, so he is hypotensive. He has central line, and they are measuring CVP. They found it 14 millimeter mercury. Measuring lactate, one from the most important item from the first hour bundle, found lactate is 6. So I receive answer before the question. So should we give this patient the fluid or not? You have 2 answers, yes or no. kindly share with me in the chat room, this patient, does he need fluid or he doesn't need fluid? Just I will give half a minute. I can see most of you going with no. Little going with yes. Oh, need fluids, no, no, no. I can guess. Okay, so the majority going with no. This patient doesn't need fluid. Let us analyze this patient. We said this patient, why yes? Why this patient you will give him fluid? He has sepsis. He's relatively hypovolemic due to vasodilatation. He have, of course, sequestration of the fluid with third space also. He has persistent tachycardia as well as high lactate. So the one who's answered yes, he has his rationales. The one who's answering no, also he has his rationale. CVP is 14 millimeter mercury is high. And he received already 4 liter. And his cardiac patient with ejection fraction 40%. So actually, this patient is a dilemma of giving fluid or not to give fluids. Right? If we'll go back to the physiology, why we are giving fluids for our ICU patients or for any patient even postoperative? Usually we have 4 indications. The first of one of them is nutritional. All of us agree that this patient needs some sort of calories, and you can replace him if he's taking oral. He doesn't need to give any IV fluid in this stage. Or you need to replace the loss, maybe from GI loss, maybe from bleeding, maybe for whatever. And I can say in the future, maybe this is will be the only indication for abnormal saline, which is replacing chloride in patient who has GIT loss, or a maintenance. Usually in anesthesia, you have a patient who's fasting, you have a patient who's NPO for longer time for any procedures, and you need to replace his fluid at the maintenance fluids. And the most important for us in ICU is the 4th indication, which is resuscitation. This is where we will focus on resuscitation of the patient, because this resuscitation is an acute stage of septic shock patient, and it has to save life. And most of the guidelines focusing on resuscitations, and any one of us giving fluids for this patient as a part of resuscitation, either for his absolute hypovolemia or relative hypovolemia due to vasodilatations. All of us agree that dehydration is bad, and the hypovolemia can affect tissue oxygenation and organ perfusion and can even lead to death. As well as evidence-based worldwide, hypervolemia also is very bad and has many complications, increasing intra-abdominal pressure, lung edema, healing of the wounds, many complications, and by evidence, it's many trials showing that increasing the mortality and decreasing ICU length of stay. So I would like to start with the messages. The first message I'd like to tell you about it: consider fluids are drugs. You have to think about it like drugs. When you are giving any antibiotics or any antihypertensive medication, you are thinking 100 times. You are worried about the side effects, toxicity, overdose, underdose. So please, when you have the fluids, you have to have the same concept. When you give fluids for such patients, you have to have the same concept. And also, it's shown when you are controlling the fluids with fluid responsiveness guided, you have a favorable outcome from ICU, as we can see it in this study done in 2017. You can find goal-directed therapy guided by assessment of the fluid responsiveness appear to be associated with reduced mortality as well as length of stay and, of course, duration of mechanical ventilations. Many studies done to prove that. So, what does it mean of fluid responsiveness? Fluid responsiveness means when you give your patient the fluid, the heart will respond by increasing its stroke volume and hence cardiac output. To achieve this target from the fluid resuscitation, you have to have a proper system. You have to have a pathway to have this achievement. First, you are relying on intravenous fluid to improve the expansion of the intravascular volume, which is increasing the stressed blood volume and consequently increasing the main systemic pressure without increasing the atrial pressure, because the venous return depends on the two pressure, forward and backward. And I will explain this one in the couple of the slides after this one. So to achieve the responsiveness of the fluid, you have to have a proper venous return, as well as you have to have a good cardiac function. The heart will respond well. He will eject stroke volume, which is increasing with the fluid you are giving. Without those pathways, you cannot achieve favorable outcome from the fluid you are giving. So let us have it in details. If we think about what targets from the fluids you are giving, all of us know we are giving the fluids for the shock patient, and we have end user. We have a cells at the end, the hypoperfusion for the cells. We want to improve organ function at the end. So think about it. If you look to the circulation, you are giving a fluid here in the venous side, if you can see it here. Assuming this fluid in the venous side will go to the right side of the heart and to the pulmonary circulation, coming back to the left side of the heart and ejected by the cardiac contractility to have a good stroke volume. On the same time, you had good vascular tone on the arterial pressure, which is driving the fluids to the tissues. And assuming you have good microcirculation, as well as the diffusion of the oxygen to the cells. So long journey to achieve between fluid infusion and the organ function. So we need to have a response for the fluid. The response, it means you have giving fluid, you have increasing this station, these steps to achieve at the end the target. It means if you give fluid, main systemic pressure has to increase, cardiac output has to increase, MAP has to increase, microcirculation have to improve from the fluid you are giving to say my patient responder to the fluids I'm giving. Of course, many barriers to achieve this. You have vasodilatation, you have high CVP, you have poor cardiac contractility, you have microcirculation derangement, you have disruption of the glycocalyx, you have many barriers on the way. You have to think about all of this. So when I'm saying fluid responsiveness, I'm saying fluid infusion has to increase the main systemic pressure, which has to increase the cardiac output. And the third step, MAP. So if we think about responsiveness, you have to think about those effects by the fluids you are giving. Let us take it one by one. Does fluid infusion increasing my main systemic pressure? First, what is main systemic pressure? If you look to the veins, looks like this balloon. When you have the balloon which is shrinking, unstressed volume inside this venous side, when you have this in venous capacitance increasing to this stage, this is called unstressed volume. Just take the shape, conformation of the venous side without exerting any pressure on the wall. All of this, we call it unstressed volume. It doesn't have a space apart, a rule in the venous return. What we have a rule in the venous return, the fluids after this stage, which is stressed volume, the volume exerting a pressure on the venous wall, this is the main systemic pressure. So if you are infusing a fluid in the venous side, you have to increase the main systemic pressure, which is a stressed volume. You have to increase it in the venous side. Not only that, if you increase the main systemic pressure, this is the forward pressure. We have another pressure high up here in the right atrium, which is the CVP. which is the right atrial pressure. If you have main systemic pressure here in the stressed volume, and if you have right atrial pressure here, so that the difference between them, this is controlling the venous return. Let us think about it. If you are increasing the main systemic pressure, on the same time you are increasing the right atrial pressure, so no effect on the venous return. What do you want to achieve from the fluid? To increase the main systemic pressure without increasing the CVP, or at least no significant increasing, because if the CVP increasing more than the main systemic pressure, no venous return, it will be decreased, so will not achieve the target. So if you think about it, you will know here the rule of central venous pressure, which is the main atrial pressure, which is the backward pressure of the venous return. For that, we did agree for the Starling curve, in the ascending portion of the curve, cardiac output can increase, right? But if this cardiac output increased, if it is associated with increasing in CVP, which is the black line here, so will not achieve responsiveness. Cardiac output will not increase. So what do we need? We need increasing the cardiac output without increasing the CVP, or minimal increasing in CVP relative to the main systemic pressure. So we need to maintain the gradients, or at least increase this gradient between the main systemic pressure and the CVP. So I think with this view, you can know what is the rule of central venous pressure here. I cannot say the central venous pressure play a role in my patient responder or not. No, I cannot say that, because it doesn't have a rule for the responsiveness. And many articles coming to tell us central venous pressure doesn't have a rule for venous fluid responsiveness. But you can use it as a safety margin. You can use it as alarming point. Central venous pressure, yes. If it starts to increase, so you are expecting the gradient will be decreased, so no venous return. So not responded, the patient will be not responded. So central venous pressure is not abundant anymore, and it is not useful anymore. So you have to know its rule in the patient assessment of the patient with the fluid responsiveness. Many assessment tools to tell you about my patient will respond to the fluid or not, either dynamic or static. Of course, static it is less reliable. Dynamic is more reliable than static responsiveness, which is change in the parameters you are measuring. So if you have static parameters like central venous pressure, like wedging pressure, like global end-diastolic volume, like flow time corrected by the cardiac, whatever the machine giving you, any static measurement, it is not a good tool to assess the response of the fluid, responsiveness of the fluid, but it can use as alarming limits. If it's increasing, you have some sort of alarm, you have to stop. What we are relying on now, the dynamic parameters. All of us hear about everything about them, either using systolic pressure or pulse pressure or stroke volume variation, or a change in the inferior vena cava or superior vena cava, or a changing in the velocity of the aortic, or a delta aortic blood flow, or even using the superior vena cava or other parameters or seismograph, many parameters for dynamic measurements. All of them relying on you are giving a fluid, challenging of the fluid, and if the patient will be responder, he will be here in the ascending part of the Frank-Starling curve, and you have a change between inspiration and expiration, whatever the parameter you are measuring, stroke volume or pulse pressure or systolic pressure variation, or whatever you are measuring, right? If the patient in the flat portion of the Frank-Starling curve, and I can tell you, everyone have its own curve. Not only that, it differs with the stage of the shock stage. You can have the patient in this stage earlier, but when he starts to have cardiomyopathy, when he has cardiac contractility poor, the curve can go down. So it is a dynamic state. So you need to assess the parameters with intervention you are giving. So we have intervention, which is cyclic change. Of the respiratory cyclic change, we have venous return change, preload will increase, and I'm assuming I have a response from the heart. As we have mentioned earlier, the stage before the heart, which is the central venous pressure and the main systemic pressure, now we are focusing on the cardiac output, stroke volume, increasing or decreasing, as well as the pulse pressure. Why cyclic change in the respiratory cycle during mechanical ventilation making this change? Because as we all of us know, mechanical ventilation increasing in intrathoracic pressure, but don't forget as well increasing also intra-abdominal pressure, right? So we have dynamic change in the lung volume. If you have a patient which is volume loaded patient, is normal patient, both of them will change intrathoracic pressure as well as intra-abdominal pressure, but pressure gradient maintained. So this patient, they have good venous return, it's constant. But for volume depleted patient, we have collapsing veins. We have narrowing of the veins. So even we have increasing endothoracic as well as intra-abdominal pressure, but the venous return will be decreased in volume depleted patient. This is a cyclic change with the mechanical ventilations. Evidence-based, many showing change in the evidence-based was cut off of 13% between the responder and non-responder with pulse pressure variation, with stroke volume variation. I can say we have a gray zone between 7 and 13. You can tell me above 13, the patient will be responder. Less than 7, the patient will be not responder. He doesn't need fluid. With high sensitivity and specificity, many studies, I can say more than 300 articles to tell me your patient dynamic change, like stroke volume variation, as you can see it here, pulse pressure variation, as you can see it here, most of them by the figures of the hemodynamics worldwide. Of course, it is better than static parameters like wedging pressure or cardiac index or CVP, right? With high specificity and high sensitivity. With cutoff 13 for both of them, as I say, we have a gray zone between 13 and 7. If you look to the articles, hundreds of articles talking about the responsiveness of the fluids, does it valid or not? With the mechanical ventilation changes, yes, it shows good accuracy and validity for the patient and good assessment for the responsiveness of the patients. Of course, another, let us say, track of ultrasound and echo, and I will keep it for our pioneers, Dr. Aid and Dr. Ashraf Taher. Actually, they have a very good, of course, experience in such. Also, the same concept. We have the intervention and we have parameters to measure, right? Whatever cyclic change of the mechanical ventilation can affect the velocity of the aortic and as well as the time integral, as well as the distensibility or collapsibility of the inferior and superior vena cava, with, of course, certain limitations. Another important message. Your patient coming to the ICU mostly late, not in the early stage, with the very common meta-analysis done by Xavier Monet and John Poole, 50% only of your patient will be responder in the ICU. So kindly don't make it as a standard of care in the ICU. Unlikely most of the patients will not be responder. And another study done by Silversides 2019 to show when your patient will be responder, as you can see it here, this blue color, over 400 patients, septic shock patient, this blue color, the patient will respond to the fluid management. And the early stage of sepsis, 57% responder. With time increasing, will not be responder. Again, I'm talking about resuscitation of the fluid, right? So please think 100 times. Check your patient will respond to the fluid or not before you will give him fluids, right? And whatever the parameters you are measured, all of them are accepted. Every test have its own setting to be used in either in hemodynamical unstable patient in ICU, post-operative patient, OR patient in the ward or in ER. Everyone have its own test to be done with the complexity of the technology of the test. But the second important message here, the limitation of each one of them. Is before you will use the tool for the patient to give him fluid, you have to know its limitation, because really it is less specific and less sensitive in these scenarios. If you have the patient with spontaneous breathing, if you have the patient with rapid AF, or have intra-abdominal pressure is high, or right heart failure, all of them can give you false positive for those patients. As well as most common our ICU patients have ARDS. They have stiff lung, they have low lung compliance, as well as low tidal volume, or patients in open chest, and very high respiratory as well as heart rate. those the limitations. So what is the solution? What we can do for those patients? We need just to change the intervention, because all of these limitations relying on the inaccuracy of the mechanical ventilation to give fluids. I cannot rely on mechanical cyclic change of the mechanical ventilation as a preloaded challenges for such cases. So what I need to do, I have to think about another intervention to do. Like I can just hold the expiration at the end to call it end expiratory occlusion test. Or I can do one from the very interesting and accurate test, passive leg raising test. Or I can infuse some sort of the fluids. Or I can change the tidal volume for the patient in ARDS from 6 to 8. And I can measure again what parameters, what the response, whatever, pulse pressure, stroke volume, systolic pressure. So the parameters I'm measuring, it is the same, but what I'm changing, the intervention, right? And I can actually say here, I will acknowledge the Prof. Sheila from Montpellier, and she's working in France with the Vermoni and Gentpool. She's the first author of the tidal volume challenging. She posted this protocol in this conference. All of us know about it since 2017 for the patient with ARDS. The patient with 6 ml per kg, she just increased it for a minute to be 8 ml per kg tidal volume, then going back again to 6 ml per kg and giving fluid bolus and checking the effect of increasing tidal volume for such patient to have a good heart-lung interaction with 8 ml per kg. Of course, the results was very, very favorable. Look at that. The left side of the figure, we have it here, the pulse pressure variation on 6 ml per kg, of course, with 8 ml per kg, as you can see it here, more sensitive and more specific, as well as also the stroke volume variation at 6 ml per kg, as well as the stroke volume variation on 8. Not only that, she have noticed another important one, which is the difference, the delta pulse pressure change and the delta stroke volume variation change. The delta pulse pressure change here from 6 to 8, more than 3.5% shows more sensitivity and more specificity closing to 100%, as well as stroke volume variation from 6 to 8. The delta change in stroke volume variation have more sensitivity and specificity rather than even the stroke volume of 8. So she's playing with the volume, with the tidal volume, to have a good effect and good reliability for the responsiveness, fluid responsiveness for such case. Another important test we have mentioned just end expiratory occlusion test. The scenario, we have the normal one during cycling change of mechanical ventilation, venous sustain will increase, cycling decrease in the preload with the expiration. So if you just hold it during expiration for 15 seconds, you need to measure the cardiac output. During that, the change in the cardiac output more than 5%, this patient consider him responsiveness for the fluid. Those for the patient have limitation for the standard fluid responsiveness test. So end expiratory occlusion test and shows actually 90 sensitivity with a 100% specificity for such case. Another amazing test, which is very easy to be done. Another way of the internal challenging for the preload, autologous transfusion of the blood of 300 to 500 ml of blood. Just raise his leg in this position, going up to this position, and check the responsiveness of that. This is the same fluid challenging, but autologous, internal transfusions. But the beauty of that, we are not giving fluids from the patient himself, as well as this effect is reversible. You can take it out and the transient. So very good test, and hundreds of articles showing the passive leg raising test in the limitation of the standard fluid responsiveness test was cut off 10% of the cardiac output, have a very good sensitivity and specificity to tell my patient cardiac output will increase with the fluid challenging for such case. So passive leg raising test, you can say many trials coming. Of course, this one by Xavier Moni and Jean Toul in 2008. They published it. Since that time, the validity of the passive leg raising test and easy to be used in ER and ICU to check your patient, he will respond to the fluid or not. And a very nice article came to tell us for the passive leg raising test, also published in 2015 in Critical Care Medicine, also by Xavier Moni, he's the senior of this study. Rather than, I do like the color of the column. Let us look at it. They measure the gradient between the main systemic pressure as well as the CVP here. They did found with the passive leg raising test, they did found it significantly increasing this gradient for the fluid responder. So what does it mean? It means passive leg raising test significantly increase the gradient between the main systemic pressure with the CVP. So those patients means responder. As we remember, the first step of the volume expansion is the venous return, which is affected by this gradient. The second step of the fluid responder is the cardiac contractility, or the response of the heart, which is the Frank-Starling curve. The non-responder patient doesn't have increase in this gradient, as you can see it here. Right? So if we look from the outside for the fluid we are giving to your patient, in the venous side, we have now two very important forces to think about it: the gradient as well as the stroke volume. So I have a question here. Let us say my cardiac output increased. I gave a fluid for my patient. I did a fluid responsiveness, is positive, and cardiac output increased. Are you sure that increasing the cardiac output can augment the blood pressure, can increase the MAP? If you are agree, just say yes. If you are not agree, just say no. Please, you can reply in the chat. No, yes, no, yes, no. Look like equal. Half yes, half no. I don't have gray zone. I don't have in between, either yes or no. Of course, if I would say maybe it would be the right answer. Okay, that's enough. Let us see. Very nice study done in 2019, published last year, actually, right? Which telling us, this is the left curve here, showing the Frank-Starling curve. Those patients preload increased, cardiac output increased. But this right curve showing the relation between the cardiac output and the arterial pressure. If you have the patient with low vascular tone, blood pressure will not improve. You need to have good vascular tone for your patient to augment his MAP, his cardiac, his arterial pressure. So it means my patient, when I'm giving him fluids, it's not as easy as it is. We need to have a gradient between the main systemic pressure and the venous return. We need to have a good cardiac contractility to augment the cardiac output. We need to have a good vascular tone to increase the main arterial pressure. For that, nowadays, you think to start, not to start, which is first, catecholamines, vasopressors, or fluids. Many studies going now to tell us early vasopressors, I think, would be better than that fluids management. Okay. I have the last question in this lecture. Let us have it. This is the last question. I'd like your opinion. Fluid responsiveness equates to the need for fluid policies. Again, my patient, he responder. This is equal. He needs fluid. Let us look to the chat. Agree, not agree. Not agree, agree, not agree, agree. Looks like most of you agree. Oh, no, not most. Walid, I think most of them agree, right?
Correct.
All of them won. Don't. Good. Okay, let me ask you a question. If I do fluid responsiveness for you, you will respond or not? All of us will respond. All of us will be responders for the fluids. I will share with you one from the most important message I want to tell you. As well as if you have the patient who needs fluids, over, clear, this patient needs fluids. The patient early in sepsis, he needs fluids. The patient is in hemorrhagic shock, he needs fluids. So don't go beyond giving fluids. Don't assess his fluid responsiveness, right? So this normal patient, this is clearly he needs fluids, right? But we are dealing with the patient who may or maybe not. In such case, please remember this message. We are giving fluids for the patient who have acute circulatory failure, number one, who have showing the responsiveness for the fluid, number two, and at the end, which is the very, very important, he doesn't have risk for giving the fluids. You are weighing the risk and the benefit. He may benefit from the fluids, apparently, as you can see in the fluid responsiveness test, but it can harm him from another way. So please remember those three messages for the patients. You give him fluids, acute circulatory failure, fluid responder, as well as no risk. Many questions coming in clinical scenario when I'm going to the patient in ICU. I have a patient in ICU, his blood pressure variation is 20, he needs fluids, I have to give him fluids. On the same time, he's bubbling, his lung is edematous, he have pulmonary edema, he have a risk. Those patients don't give them fluids. And it's clearly mentioned here, when you have two graphs together, Merrick curve for the extravascular lung water here and the Frank-Starling curve. Look to these two curves. Here, this patient responder with the fluid, yes, because he have large increase in the stroke volume here, as you can see it here. When you give him preload, large increase in stroke volume. Because those patients have gradients, still have the gradient between the main systemic pressure and CVP. Those patients have small increase in the extravascular lung water when you look to their curve, their curve here, small increase in extravascular lung water. If you look to another patient here, it can be responder. We have a small increase in stroke volume here, but we lost the gradient. CVP increased, main systemic pressure increased, but the gradient lost, decreased. Those patients on the same time showing large increase in the extravascular lung water. So when you combine those curves, giving you the message, please, even if your patient responder, you have to think about the third, there is no risk. Extravascular lung water, one from the very, very good tool, assist for the patient who have overloaded of the fluid and sensitive and showing us with the 50% and more, higher 50% with the 20% and more, 50% of the patients will die. So fluid responsiveness in a reasoned way, simply check assessment condition, check limitations factor. If you don't have any one of the limitations factor, just go with the dynamic indices, the standard one, pulse pressure variation, stroke volume variation. If they showing positivity, give fluids. If they are in the gray zone between 8 and 13 or 9 and 13, or if you have a limitations for those, you have to think for another alternative fluid response, another intervention to assess the fluid responsiveness, which you have just mentioned now, either tidal volume challenging, fluid bolus challenging, passive leg raising test, and the expiratory occlusion test. Those patients, if showing positivity, those they need fluid, but there is no risk, there is no harm of giving them a fluids, because those usually assessed late when they start to have lung edema. So consider those patients without risk of the pulmonary edema or whatever. If no, think about another way like vasopressors, like inotropes for such patients. Okay, another benefit from the fluid responsiveness, which I'm feeling more important than giving a fluid. Yes, when you're taking a fluid out, you need to check fluid responsiveness. Those patients, not responder, don't get fluid. Stop fluids. Not only that, when you are giving fluid out, just take a look on hemodynamics. Again, central venous pressure. When you're taking a fluid out, you are decreasing the mean systemic pressure. You are taking the intravascular volume out. On the same time, you have to decrease the right atrial pressure here. So you are maintaining the gradient. So you are maintaining the stroke volume. Once the stress volume decreased without decreased in the central venous pressure, stroke volume will decrease. So when you're taking fluid out by ultrafiltrations, you have to monitor the patient hemodynamically to tell you, please stop. Stroke volume start to impair. Central venous backward, the pressure start to stay higher than that the intravascular pressure. So you can use them. If we now understood the venous side as well as the cardiac output, as well as the vascular resistance or the manual arterial pressures, are we guarantee the patient will respond and organ function will improve? We still have another big, let us say, place or stage, which is the microcirculation, which I'm believing still not yet in well practice, in clinical practice, but it has to be. Because when you are augmenting the blood pressure by the fluid you are giving at the beginning, you are relying on two factors for delivering oxygen to the cells. The convective pressure here in the microcirculation, as well as the diffusion of the oxygen here, which is called diffusion distance. This is at the level of the microcirculation, right? So if whose patient will respond for the fluid at the level of the microcirculation, the patient will increase his convective microvascular flow. On the same time, don't think the edema on the extracellular fluid here, it is cosmetic only. No. Look at this one. The diffusion distance will increase if you have edema in the tissues. Oxygen delivery will decrease. So edema is not cosmetic. It is affecting the delivery of the oxygen. So at the level of the microcirculation, I think we need to have also microcirculatory responsiveness tests on the level of the convective flow on the microcirculation, as well as diffusion capacity or diffusion distance of the oxygen on the level, which is not yet well in clinical practice, but we have it. So who will respond to the fluid? Who will get benefit from the fluids? As you can see it here, he has to have preload responsiveness patients, good cardiac contractility to increase the stroke volume, optimizing of the cardiac after load. This is for the macrocirculation optimization to improve, to have the effect of the fluid on the microcirculations. I have something here just to add because I just read it about the new technology which is added in the intraoperative. Personally, I didn't use it yet, but I read about it. They have some sort of prediction whose patient will have hypotension after 10 or 15 minutes. They have an analysis of the high technology of the arterial pressure waveform using contractility effect, aortic complier, systolic phase, the carotid notch, everything to show us what is called hypoprediction index. Look at here, intraoperative studies, they show blood pressure here on this curve and prediction index of hypotension here. When they found hypotension prediction index more than 90% increasing, so those patients after 15 minutes here, they will develop hypotension. So it's a very good prediction. to tell you your patient will be hypotension after 10 to 15 minutes. How it looks like in the screen, you have the curve of hypotensive prediction index. And when you have this curve, the curve will give you alarm. Take care. Your patient after 15 minutes or after 10 minutes, he will have hypotension. And it will give you another screen. Maybe due to preload check, maybe due to contractility, which you have another assessment for contractility, maybe which edine, another effect of the afterload. So you have to think about those patients, why they can develop as a prediction for the hypotension, mainly intraoperative. Published in Anesthesia and Analgesia, and you can see it here, hypotension prediction index with timing 15 minutes still have the sensitivity and specificity of 80%. Look at here, those with timing. Of course, earlier, more sensitivity, later 15 less sensitivity. But at least it can tell you at an assistant inside OR, your patient can be hypotensive after some time, after a few minutes. I'd like to conclude with 4 messages. First one, assess fluid responsiveness using dynamic indices. Second, even if your patient is responsiveness, just remember, we are giving fluid for the patient who have acute circulatory failure, who doesn't have no harm from the fluid. There is no risk of the fluid management. Passive leg raising test can be used in situations where the heart-lung interactions are unreliable. No test is perfect. You have to integrate. It is a puzzle. You have to integrate together to reach with your clinical assessment. It is very essential to reach the final diagnosis of your patient to respond or not. Thank you so much. And I'm willing for the question.
Perfect. That's very good, Dr. Ahmed. Thanks. As usual, very comprehensive pathophysiological principles, technicality, and modes of resuscitation here. Allow me to stop your PowerPoint presentation. Good. So we have a couple of questions here. We'll start with them. How can we suppose to take central venous pressure or right ventricular pressure just as an alarming parameter, while it is a main component of venous flow during the pressure?
Central venous pressure, generally, right? It is not a test for fluid responsiveness, but I can say if you have a low central venous pressure, yes, you can use it to give some fluids. Some literature giving some sort of even central venous pressure variation to give some fluids. This is in basics of the ICU, right? But when you have little bit higher, please, you have to think, you have to stop. The limitation usually coming with higher CVP, so don't rely on, right? And central venous pressure, I will not take it out because all perfusion pressure relying on central venous pressure, right? So I hope you can use it if you have low number, low figures, but when you have higher figures, don't rely on it.
Perfect. So I may still add one note here, Dr. Ahmed, if you allow me. I had seen some patients with aggressive fluid resuscitation, 10 or 11 liters, and they became anuric. The abdominal pressure is very high, so they have IVC diameter and indices in the very low state. And depending on that, whoever was at bedside with IVC diameter index, suppose giving an IVC of less than 10 or less than 5 centimeters, because no central line at this moment yet. Patient was in ED, didn't have a central line, so they kept giving more fluids and more fluids while the patient has a compartment syndrome. So the message here is like, take care of strange scenarios that may come in, or don't be confused with when the CVP is really low or there's something that's causing a false low CVP. That's why we don't trust CVP. Do you agree with that?
Yes, sure. Because actually, if you again going to the physiology with the Guyton curve, you can find the area of, we called it waterfall area. In this area, you can find the IVC even collapse it, right? But you cannot rely on, you cannot say this patient will need fluids, right? Because automatically with high intra-abdominal pressure, the fluid can go without. So this is, don't rely with high intra-abdominal pressure with such case. Again, it is in the context of puzzle. You have to think about it. Those patients, I'm agree with you. What you have to think about. Personally, I'm not relying in CVP for any management of the fluid for any patients.
Perfect. And on the contrary side, another confounding factor when you have a patient of ARDS or high PEEP or high mechanical ventilation setting, or even with a pulmonary embolism.
Yes.
So
Right
you
side
still,
failure. Yes, yes, yes.
yeah,
Many limits.
you may still give fluids to augment right ventricular output in these scenarios. So patient will have a CVP of 20 and we're still giving fluids. So CVP is actually not reliable at all for fluid resuscitation.
Yes.
Particularly, I always say we are judging the right ventricular pressure to judge a left ventricular end diastolic volume. It's a long journey from right atrium to the right ventricle to the lung or the pulmonary circulation back to the LA and LV. Actually, you are judging the LV pressures, and with grade 1 diastolic dysfunction, you lost the correlation of pressure volume relationship between left ventricular pressure and volume. So this is the very first relationship you have at the level of left ventricle. Imagine the reflection on that on the right side after all this long journey. So CVP is nothing, if you agree with me.
Yes, and actually, I here appreciate so much the ultrasound and the echo because it can give you the full picture of the pulmonary, of the right side, of the collapsibility, everything. So I really appreciate here the echo and the ultrasound to be used in this scenario, which is a common scenarios, which is almost misleading, right? Because most of the ARDS patients have right ventricular dysfunction. They have whatever diastolic, as Walid said, you have pulmonary embolism. So all of them misleading if you are relying on the central venous pressure as a measurement, either even to get fluid or even to assess the right side of the heart.
Perfect. And here comes actually, Dr. Ahmed, the second question, which what is the easiest reliable way to check the microcirculation, the micro circulation, not the macro circulation? Do you think echo bedside to measure cardiac output by echo is enough? A question by Dr. Ahmed Kuhil.
For microcirculation.
Yes.
No, no, microcirculation actually it is another big place or field. We need to think about it. For microcirculations, you have two steps. First one, the microvessel itself. The second one, it is the cell function itself, right?
Mm-hmm.
Let us say microvessel itself, we can rely on some sort of tissue oxygen saturations, which is still even like near infrared spectroscopy. But the most important one, which is the cytochem imaging of the microcirculations, which is well developing. Ken H and the Becker, the figures of those now, and they are very excellent. Not yet in practice, sublingual camera or cytochem. This is the most important one for microcirculation. But we can rely on the third part, which is the cells itself, the biomarkers. Go to the biomarker to assess you the perfusion there. You can rely on the lactate, you can rely on the carbon dioxide gap, you can rely on the mottling, you can rely on the venous. Another biomarkers you can rely on for the microcirculation.
So during the third question coming here, Dr. Ahmed, allow me to document the attendance. So please feel free to remove this pulse screen from in front of your self. So a question from Wala Al-Ali. In cases of IVC mass or a thrombus, that will how or what will be your fluid management strategy, and what about the pulmonary embolism cases? So I think we went quickly through this one, but it's a bit, it needs actually to be answered.
And it's a very hard scenario to have the patient with IVC mass, but of course we'll not rely on the intravascular assessment of the CVP or whatever. You need to assess the pathology, how it's compression, and the pulmonary embolism. Also, the very important And I will tell you my clinical part. I'm not going with the fluids with the pulmonary embolism as aggressive as any patient of septic shock patient because you have right out ventricular flow obstructions. So you need, if you are increasing your fluid, you are almost worsening the right side, you are compromising the left side. So I'm not going aggressive with the patient with pulmonary embolism. For intraventricular mass, of course, intravascular pressure are not relying on. You need to have assessment of the cardiac function. You need to be with the fluid challenging and assess how is the fluid response from the other side for the cardiac output. But not rely on the central venous pressure or any pressure while you have mass inside the intravascular inferior.
Uh, can I summarize, Dr. Ahmed, and correct me if I'm wrong? Fluid resuscitation starts from the history taking. So if the patient is septic for the last 4 or 5 days and he is NPO because of sepsis, I'm expecting this patient at least to get 2-3 liters of fluids before we need the vasopressors or we kick in with the vasopressors. Then examination, examine the patient well. Is there any lower limb edema, pulmonary edema, any murmurs on the heart to say there is a aortic stenosis or mitral insufficiency? Clinical examination is very important as well. See the jugular venous pressure. Then, after you examine the patient, start use the investigations like lactate and perfusion parameters, central venous saturation, and then use the simple aids of ultrasound and echo to add the last piece of the puzzle. And you can use passive leg raise test, dynamic parameters, but I think it's all together. It's never a one box to be ticked, and this is the best thing for all patient. No plan fits all. If you agree with me or you have any other
Of course,
proposal.
يعني I can say Walid is minded by the European Society hemodynamic modules. What he's mentioning now, it is exactly present in the hemodynamic module. You have initial assessment for the patient and you have advanced assessment. The initial assessment in hemodynamic module of the EDIAC, the first one, of course, medical examination, assessment, GVB, cardiac ECG, even history, lactate, and the third step, you have to go with fluid responsiveness as course, fluid responsiveness now in all guidelines of septic shock patients. And the advanced technique, you have to go with the more advanced technique. So this is the let us say, stepwise or the flow chart to assess your patient in hemodynamic way, right? But I just want to remind you, the septic shock patient, you have to check. Usually, when he coming to, the timing is very, very important for septic shock patients. He's coming from ER, he's coming from another hospital, he's coming from home, and he's landed in ICU. Usually, they did find that fluid microcirculation responsiveness for septic shock patients, it doesn't happen after 24 hours to 48 hours. Nothing to be done with the resuscitation after 24 to 48 hours with septic shock patient with microcirculation. So those patients resuscitation as early as you can. As I mentioned the earlier, responsiveness will be with delayed time, the patient will need to be responder. So timing is very essential to assess him. For that, I think, I don't know you have it in Europe or that, Walid. There's some, I heard about it, there's some like smart code or code, sepsis code team, which is announcing like code blue for septic shock patient with some of the scores, which is very likely to assess the patient in sepsis. They announce it for the smart code or the sepsis code team. They are going very fast with the fluids, with the antibiotics, with everything to manage the patient as life-threatening, as emergency, as early as they can for the fluid, for the antibiotics, for whatever the septic shock bundle or the sepsis campaign bundle. Because, of course, all of you know, one from the highest mortality reason for the worldwide with the sepsis, and they are fighting, and it's preventable. So they are fighting it as early as they can. I'm agree with the stepwise approach for the hemodynamics.
Perfect. So I think we're finishing here the first lecture. My full appreciation and thanks to Dr. Ahmed Mady for his wonderful and fantastic presentation tonight. And we'll go ahead